Good day and welcome to the Living and Thriving with Acute Myeloid Leukemia conference call hosted by the National Bone Marrow Transplant Link. Today's conference is being recorded, and at this time I'd like to turn the conference over to Jennifer Gillette. Please go ahead, ma'am.
Thank you, Catherine. Yes, my name is Jennifer Gillette, and I'm the staff social worker at the National Bone Marrow Transplant Link. I'd like to welcome you to our Lunch and Learn with the Link. This month's program will focus on living and thriving with acute myeloid leukemia. A special thank you to our sponsors, the Leukemia and Lymphoma Society, Jazz Pharmaceuticals, Insight Corporation, Pharmacyclics and Janssen, and our esteemed Link partners for making this program possible today. Just so everyone knows how today's event will go, we will have a few moments of introduction about the National Bone Marrow Transplant Link, and then we'll hear from Dr. Harry Erba, and then survivor Debbie Beavers, and then we're going to open the rest of the floor or the rest of the hour for questions. So for those who may not be familiar with the link, our mission is dedicated to helping individuals and their families from diagnosis through survivorship. We provide resources, support, and education. Some of the resources we provide to help families navigate their transplant journey are webinars, our podcasts, blogs, our lunch and learn calls like the one you are on today, and these are on a variety of topics. We often cover chronic graft versus host disease, disease-specific information, caregiving, coping, treatment options, and survivorship. We have a wonderful peer support mentor program for patients, caregivers, and donors, our Second Birthdays Recognition program. We also have books, referrals, and emotional support, as well as resource development from our licensed social worker. Please feel free to reach out to us if you're interested in any of these services. Before we begin today's program, I would like to review a few housekeeping items to maximize the experience of all on the call today. Please be mindful in being concise with questions so that we may answer as many as possible today. Also, please note that the information provided in this program is meant to stimulate conversation with you and your own healthcare provider and is not meant to replace your individualized medical plan. Now on to the educational part of our program. We're so very thankful to have our first speaker here with us today, Dr. Harry Erba. Dr. Erba is a clinical investigator in the Division of Hematologic Malignancies and Cellular Therapy in the Department of Medicine at Duke University Medical Center. He serves as the Director of the Leukemia Program and Director of Phase 1 Development in Hematologic Malignancies. He is also the Chair of the SWOG Leukemia Committee. He is interested in the clinical development of novel therapies for acute myeloid leukemia, myelodysplastic syndromes, and myeloproliferative neoplasms, and acute lymphoblastic leukemia. Specifically, he has been the principal investigator for small molecular inhibitors, antibody drug conjugates, and cytotoxic chemotherapy. He is a graduate of Stanford University and performed his fellowship and residency at Harvard Medical School. Thank you so much for being with us today, Dr. Erba.
Well, thanks for inviting me, and it's a pleasure to speak to your group and all those on the line. Thanks for joining us for this Lunch and Learn opportunity. I will preface my remarks by saying I am not a physician who specializes in bone marrow transplant. I'm a physician who takes care of people with acute myeloid leukemia. Many of my patients do proceed to allogeneic stem cell transplants or bone marrow transplant, but the majority of patients with acute myeloid leukemia are older, with a median age of 68 to 70 years old in the United States, which often precludes the possibility of bone marrow transplant for those patients, especially if they have other comorbid illnesses, heart disease, kidney disease, liver disease. But I'm pleased to have with me today one of my own patients who will share her journey, and I'm going to talk a little bit about her medical care because I think it's a great illustration of where we are going with the treatment of acute myeloid leukemia, and does include some aspects of allogeneic bone marrow transplant. I like to begin this with a discussion of the beauty and spectacular nature of our own bone marrows. Deb, my patient, may have heard me say this before, but it's quite amazing what our bone marrows do. For our entire life, the bone marrow is responsible for producing blood. All of the blood cells that float around in our blood vessels have a finite life expectancy. Red cells live about 3 to 4 months, platelets about a week. White cells that fight infection, maybe about a day before they go out into the tissues to fight infection. Now, because of this, if the bone marrow doesn't continuously make blood, the bone marrow fails. And acute myeloid leukemia and myelodysplastic syndromes, what used to be called a pre-leukemic condition, are ways that the bone marrow will fail to produce blood. Now, we have learned that for this to happen in the bone marrow over time, these cells have to constantly be replenishing themselves, right? You're not born with an infinite number of cells to populate your blood for the rest of your life. And so the bone marrow has to constantly generate new cells. And when it does this, the cells have to duplicate. They have to divide and faithfully replicate the DNA, the genetic code of one cell into the 2 daughter cells. There are mistakes that happen along the way, and these cells have repair mechanisms, but unfortunately the repair mechanisms sometimes fail. And so one of the reasons that we have observed that acute myeloid leukemia and myelodysplastic syndromes are more commonly seen in older people is because people have lived long enough for these mutations to accumulate. Now, sometimes these genetic changes that are occurring in the person's bone marrow have no consequence on blood formation. It's a silent mutation, we call it. Sometimes it's such a deleterious change that the cell dies. Well, we'll never know about it. But sometimes these genetic changes will lead to some kind of advantage for the cell to proliferate and stay in the bone marrow and not go away. And we have learned that there are different types of genetic changes in different classes of enzymes that code for different classes of enzymes and proteins that are most likely to be responsible for this change. Now, another thing that we've noticed is that as we age, we are all collecting these mutations in our bone marrow. In a study of blood donors who do not have cancer, including leukemia, 10% of the people over the age of 65 who just donated blood, when we looked in their blood cells, we could find some of these genetic changes that are commonly found in acute myeloid leukemia and myelodysplastic syndromes. And these people, I should say, they're not patients yet, these people have a 10-fold higher chance of developing cancer. But you need to have a complement, a complete kind of menu of different genetic changes, not just one that ultimately leads to the leukemia. Now, some of these genetic changes cause the cells to have a proliferative advantage, meaning they just start growing out of control and replicating and fill the bone marrow with abnormal cancer cells called blasts. A great example of that, most common example, is FLT3, FLT3. Other genetic changes block the normal development of blood in the bone marrow. For example, IDH1 and IDH2 are genes that are mutated that will lead to a block in normal development. And other genes are just overexpressed over time that can lead to the cells not dying appropriately, such as BCL2. Now, I focused on those three because we have made great advances in the care of people with acute myeloid leukemia based on the knowledge of these genetic changes. So let me give you an example, and we're going to talk about my patient that is joining us today. She's around Deb, is it okay if I give your age? I don't, I want to be respectful of that. Hopefully it's okay. So Deb is a 69-year-old woman who was diagnosed with acute myeloid leukemia. And this was back about a year ago, July of 2019. And when she presented, we commonly now do genetic analyses to see which genetic changes are present. And I'm going to show you why this is so critically important to do these days. So in her bone marrow cells, in her cancer cells, we found two genetic changes. One was in the gene IDH1, isocitrate dehydrogenase 1, and the other one was in the gene FLT3. These are the two genes I just mentioned, being some of the more common genetic changes that we see. And they typically don't occur in isolation. The average number of genetic changes that we see at the time of diagnosis is about 4 in a cancer cell. So it's a complicated mixture. Well, my patient received the standard chemotherapy we've been using for 40 years, and she did not have a remission with it. The disease was still there. That happens about 20 to 25% of the time. So we then gave her another type of chemotherapy, but this time with a drug that has been developed to turn off FLT3, and that's called Mitostorin. Mitostorin, when added to chemotherapy for young people with, well, for anyone with previously untreated AML that has one of these FLT3 genetic changes, has led to a better chance of surviving the disease. And so the FDA approved it back in April of 2018, 17, a couple of years ago. Well, unfortunately, her disease didn't read the book, didn't read the prescribing information, and the disease was still there. So we then gave her the standard thing to do is to give chemotherapy in that situation. And again, with a higher dose of chemotherapy, and again with that Mitostorin, but unfortunately the disease was still there. And here comes the advances now, because if this was 10 years ago, my patient wouldn't have had many options at that point. But I knew that there was this IDH1 genetic change, and a drug has been developed that turns off the adverse effects, the ill effects of this IDH1 genetic change. The drug is called Ivocitinit. And so it's a pill, and she took the pill, Ivocitinit. I gave it with a low dose of a much milder chemotherapy because the combination has been shown to lead to responses in 80% of people. And this time her disease did read the book, did read the papers, because she ultimately had a complete remission. And so in her, the genetic change, FLT3, even though we targeted it with a drug called Mitostorin, didn't respond. When we treated her with a drug taken by mouth that targets and turns off IDH1, she achieved a complete remission. And by doing so, we were able to then move on to transplant. And so she received a conditioning regimen, chemotherapy prior to the transplant, and then the bone marrow transplant about 6 months ago. Now, we know, unfortunately, that one of the biggest challenges we have in our patients with acute myeloid leukemia who undergo transplant remains relapse. And so after discussion, she and I decided to put her back on the drug that had resulted in the remission in the first place, Ivocitinib, because in general, she has tolerated this oral medication very well, much better than intensive chemotherapy. And so, you know, that's her story. And the important lessons here are, it's important to do genetic analysis at the time of diagnosis of AML, at the time when the disease is still present despite standard treatment, so that we could find a target for one of these new drugs that are now FDA approved. The second is, she's 69 years old. And when I was training back around 1990, we really didn't consider doing bone marrow transplants for 69-year-old people, even though they would be otherwise healthy, like my patient, mostly because of the intensity of the chemotherapy and the inability to tolerate that. But we are now able, with modern, with newer conditioning regimens, less intensive preparative or conditioning regimens, with drugs to prevent graft versus host disease, with better drugs to treat infections and prevent them, we were able to do transplants for people in their late 60s and even 70s with acute myeloid leukemia once it's been put in remission. So I'm going to come back to my patient, let her talk to you about her path, her journey with this diagnosis. But I want to come back to just one other advance or summarize one of the many advances that we've had recently. And this is an advance for the majority of our patients with AML. Remember, the majority of people with AML are over the age of 65 to 70. Okay, the average age is around 68. So the majority are older, and unfortunately, the majority of those people were not able to tolerate the standard chemotherapies we've been using for decades. Just too intensive, it actually could shorten survival in some people. So our data has shown, when we look at Medicare data, for example, that in the United States until recently, almost 2/3 of people over the age of 65 never got any treatment for AML. And this is a pretty aggressive disease where the average life expectancy without treatment was only 2 months. But even with treatment that we had, the average life expectancy was only 6 months. So clearly, we had a lot of work to do. I've been fortunate to be involved in the development of some of these agents, and the one that many of us are now excited about and has led to a true change in the standard of care just recently is the addition of a drug, an oral drug, that inhibits BCL2. BCL2 is an example of one of those overexpressed proteins that prevents cells from dying, like cancer cells. The studies that we have done have now shown that a combination of this oral drug, venetoclax, with, again, a low dose of chemotherapy, and there are two or three of them that we can use in that situation, given as an outpatient, can lead to complete remission rates at a much higher rate of around 75% in patients with acute myeloid leukemia who are older and would not have gotten any therapy because they were older and sick with other comorbidities like heart disease or kidney disease. But what was just presented this past weekend was the results of a large international trial that showed that not only were the response rates higher with this combination, but compared to people who were getting the standard of care in that age group, just the azacitidine alone, the survival was longer. Now, the average survival is still only 15 months, but what impresses many of us is that more than 2 years later, about 40 to 50% of the people are still alive. And some of these patients were able to undergo stem cell transplants even in their 70s. And so finally, we could say we're making some headway into the outcomes, the treatment outcomes for older people, the majority of people with AML. Still, we have a ways to go. It's 75% response rates, not 100%. Its average survival is of 15 months, but we need to go longer than that. And there are certain subsets of patients who don't have such durable responses. What we are doing now is we are investigating drugs that target these genetic changes and overexpressed proteins that lead to acute myeloid leukemia. And there have been a number of impressive examples of how new agents that are not chemotherapeutic agents but targeted therapies are helping people with acute myeloid leukemia. This is one of the things that I'm most excited about in the treatment and caring for my patients with acute myeloid leukemia. So there's a lot to be excited about here. We still have a long way to go. And at this point, I think I'll stop and pause and let my patient speak. We're about 20 minutes into the hour. And I'd be glad to come back and give more details.
Thank you so much, Dr. Erba. This is Jennifer, and I'm going to hand it over to Debbie in one moment. But I thank you so much for sharing that information. Talk about being hot off the press just this last weekend. I don't think it gets better than that. And it's certainly very hopeful to hear the changes that are happening with AML. And yes, now we would like to introduce Debbie Beavers. Debbie's a retired school teacher from North Carolina, and now she likes to lead tours for her Parks and Rec department for the seniors there when, of course, COVID is not getting in the way. And she did receive the allogeneic stem cell transplant for AML, as Dr. Erba has said, and we'll give her a chance to tell you what she has gone through and also some ways that she's coped along the way as well. Thank you, Debbie, for joining us.
Thank you for giving me this opportunity. I certainly appreciate it. First of all, I will clear up something. Yes, I am 69, Dr. Erba, but if you remember, Dr. Deal said that physiologically I was only 58. So keep that in mind. Thank goodness all my exercising and walking and getting my steps in has helped me. And I think that part of being a success has been that I was healthy and I didn't have any underlying problems. And that's a good reason to keep yourself in good shape. I guess one of the first things people ask me about this leukemia is, how did you know you had it? How did you get it? You know, that type of thing. And for me, it was very sudden. I had carpal tunnel surgery on a Monday. And my doctor had said, if you sleep with pillows underneath your head and your arm up, it'll cut down on the swelling. But he failed to tell me I'd be snoring. So each night when I went to bed, I'd be snoring so badly, I'd wake myself up, I'd wake my husband up, and pretty soon, by the end of the week, my throat was so sore from the snoring, I thought, that I could hardly swallow. So that following Monday, I went to my GP, and she looked at my throat, and she said, my goodness, I said, it's very, very swollen and red, and I don't know what's causing it. And she swabbed it. She said, I don't think it's strep or anything. She started me on an antibiotic, and she said, we'll try this. If this doesn't work, well, it might be a virus, but I want to get a blood sample before you leave. So that morning, she got the blood sample. That afternoon, she called and said, I really need you to come back and do another blood sample. Well, I thought she meant to come back to her office. She said, no, I want you to go to Raleigh-Duke, which is a larger hospital in Raleigh. So I went the next morning. She had everything set up, and they took about maybe 15 or 20 vials of blood from me, and I thought, oh, goodness gracious. And the lady said, the nurse there said, you'll know by the end of the week the results. And I said, fine. The next morning, which was Wednesday the morning, which was the 26th of June, I get a call about 8 o'clock from my doctor, and my doctor is also a friend. She and I have traveled together. And Shelley said, Debbie, did you tell me you were going to the beach for the next week? And I went, yes. And she said, well, you're not. I said, I'm not. She said, no, you are very, very sick. And I said, Shelley, you got to be kidding. What's wrong with me? She said, well, you have acute myeloid leukemia. Do not look this up on the Internet. Tell KC, that's my husband, do not look it up. You just hang in there today, pack yourself a bag, because you're going to be in Duke tonight. She said, so don't you worry about anything. I'm going to try to take care of everything. And she said, it's going to be all right. She said, this is not a good thing to have. It's a mountain you're going to have to climb, but you're strong, and you can do it. And, the good Lord puts the right people in the right place at the right time. And that's how I knew I had leukemia. Then they didn't have a bed for me that particular night, so I had to go the next morning. And I met several doctors. Dr. Erba works on a team. They have rotating doctors, so you get to see a lot of different people as well, all of which were wonderful, absolutely wonderful. I couldn't ask for a better place to go or better people to work with. They kept me informed. They told me what was going on. I felt very knowledgeable. I felt very safe. And I felt a very close connection with those people I felt like they wanted me to get better, and they were doing everything that they could. I was one of those very fortunate persons. I didn't have very many side effects. I did have a blocked salivary gland, which had to suck a lot of lemon candy. And I didn't have very many mouth sores, so that was good. I had something they called gut grinch, which was, I guess, a C. diff, I think, but I didn't have a bad case of it at all. I mean, I hardly knew I had it, but it did require people to wear a gown and gloves and masks when they came in to see me. But in the long run, that might have been good because they were extra precautious, so I never got any infections or anything like that. I did experience, and I took quite many chemos. You heard Dr. Erba talk about the different chemo treatments I had, and I can't really remember after which one, but after one of them, I did have what they call the rigors or the tremors, and they don't last very long, and they got this wonderful drug called morphine they'll shoot you up with, and you just don't feel the pain. You go right on to sleep. So that's really the only inconveniences I had. I was able to walk each day, and most days I got my 10,000 steps in, and I did my exercises in the morning. I didn't lose my appetite. I was able to eat. I was very lucky to have good family support. My husband visited every day. I have one daughter, and she visited quite often. I had friends. Dr. Erba let me play bridge at least once a week. And it was a wonderful journey to have to go on if I had to do this. All the bumps in the road came along with a lot of blessings. I got lots of support from my family, my friends, and the staff at the hospital. I don't know what else you want to know. I think I was truly blessed. The Lord put me in the right place at the right time. Dr. Erba is a fantastic doctor. If plan A doesn't work, he's got a plan B. And if plan B doesn't work, he said, don't worry, he's got a plan C. So I never felt like I wasn't going to get cured or get better. There was always their hope. I don't know what else. I don't know that I've talked 10 minutes because Dr. Erba told you about all this stuff. I tried to write down some of those drugs. Sure, I'm glad he was able to tell you about them because he knows how to pronounce them a lot better than me. And now I'm on I don't know what he said I'm on, but I thought I was on Tocebo. And Tocebo is the drug I'm taking, that chemotherapy, but he knows the real name for it. And knock on wood, even after my transplant, I've not had any trouble. My transplant went very well. And like he said, he wasn't my doctor then. I have a transplant doctor from the Bone Marrow Treatment Center. And my transplant went very well. You do take chemotherapy again, a very rigorous one. But I only had a couple, maybe 2 or 3 days I didn't feel too good, or a couple of days when I couldn't get my 10,000 steps in. So I felt good about that. I was very blessed. A lot of people get sick and have to throw up, and I probably didn't throw up more than 3 or 4 times. I did scare Dr. Erba one day by fainting, but we still couldn't figure that one out. He happened to be on the outside of my door getting ready to come in. So it was just one of those weird things that happen to you that they can't explain, but I was perfectly okay. The only problem is I had to wear yellow socks and say I was a fall risk for a while, but that too passed. I'd be glad to answer any questions that you had. After transplant, you know, there are some rules and regulations that you have to go through, restrictions. I do live out in the countryside, so I can't drink well water, so I have to boil my water or drink bottled water. I mostly drink bottled water. And there's certain foods and ways you have to cook your food and that type of thing. I'll tell you some cute little things. They told me to wash my fruit like grapes, soft-skinned things, in vinegar. Well, I just sort of took that like you took vinegar and you soaked them in vinegar and then scrubbed them clean. And then I got to reading the details there. It says 1 tablespoon of vinegar to a gallon of water. And I thought, no wonder my fruit has a vinegary taste. But anyway, there's a lot to learn. And like I said, I've been blessed all along the way with wonderful doctors, wonderful nurses, and just blessings along the way. And I thank Dr. Erba and all the doctors and nurses up there that have been so wonderful to me and are so smart and know so much. I've learned a lot that I never had any idea I'd ever need to know. But they're very good at explaining lots of things to you. And I'm glad that they are keeping on, because they're going to, as Dr. Erba said, they might not find cures, but they're certainly going to find treatments to help people, and he certainly have helped me, and I appreciate it.
Debbie, go ahead.
Yeah, Debbie, you brought up one of the things that confuses our patients so much. I mean, there's so many medications we use, but then on top of it, we have a generic name, Ivocitinib, then we have a brand name, Tibsovo, and then sometimes we even call it by the investigational name. Like when I was the clinical investigator helping to develop Ivocitinib, we called it AG120. And so we have multiple names for the same thing, but that's how we keep it a small little club.
You have to be in the club to know it all.
Well, Debbie, I want to thank you. You are just a genuine delight, and I'm sure you're going to give a lot of people hope with this information today, just hearing you and your positivity going through this. And now a part I'm sure a lot of people are interested in is our question and answer portion. So, Catherine, if you could please guide everyone on how they can ask questions to Dr. Erba or to Debbie today.
Thank you. If you'd like to ask a question, please signal by pressing star 1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow the signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Please state your name before posing your question. Again, that is star 1 to ask a question. We'll pause just for a moment to allow everyone the opportunity to signal for a question. Now we'll take the first question. Please go ahead.
Hello, can you hear me?
Yes, we can. Go ahead.
Hi, this is Barbara Kelly, and I have a question about Seraphinib or Nexavar. I had my stem cell transplant in August of 2015, and the following January, my oncologist, my stem cell doctor, put me on 400 milligrams of Nexavar, which is FDA approved for different uses and off-label use, and I've been on it for 4.5 years now, just recently cut back to 200 milligrams. Dr. Erba, where does this fit into the treatments for post-transplant people?
Thanks for that question. That's a really important one. As I alluded to with Debbie, unfortunately, we are still faced with the problem of relapse in our patients with acute myeloid leukemia who've gone through allogeneic stem cell transplant. And so we're trying desperately to find ways to reduce the risk of transplant relapse without increasing the side effects that a person may already have from having gone through the transplant and being on all these other drugs. Seraphinib is a oral molecule, oral drug that inhibits FLT3 and a number of other enzymes. And just as you said, it's FDA approved for a different indication in solid tumors. But what we've learned from a study that was done in Germany is that in people with AML with a FLT3 mutation who've gone through an allogeneic transplant like you, if they took Seraphinib compared to a sugar pill, a placebo, their chance of relapse and survival was greater than people who did not. Now, one of the challenges is, well, how long do you need to take a maintenance therapy like that? The German study that was called the SORMAIN trial, SORMAIN, Seraphinib maintenance, in other words, they only gave the drug for 2 years, but quite frankly, that was an arbitrary selection of 2 years. So we don't really know if the benefit would continue or not continue if a person were to take it for longer periods of time. And of course, you start getting into the issue of some of the side effects, high blood pressure, kidney dysfunction, rashes. So we don't know the answer to that. Now, one of the things that we think may help in figuring out how long to continue is if we don't detect the disease anymore by a process known as measurable residual disease, very sensitive test that might still be able to detect the disease. But that's investigational. So at this point, it's hard for me to tell you how long to continue on this drug. And I'll tell you what I do as a physician when I have this discussion with my patients. In fact, I had this discussion with Debbie when we started it. Her drug is, we'll start it, but the only way we know it's quote unquote working is if the disease doesn't come back. In other words, we only learn that it didn't work if the disease were to come back. So we don't really know when to stop it. So my recommendation is if you don't have any toxicity from it, which would be the side effects I mentioned, or financial toxicity by, if the copay is very high, then I would recommend staying on it. And it sounds like that's what your doctor's doing too. It sounds like he's more afraid, or she's more afraid of the cancer coming back than any side effects that you might be having from the Seraphinib at this point. But there are many other trials looking at inhibitors to try to, or other drugs to try to decrease the risk of relapse after stem cell transplant. Gilteritinib, there's a study of that FLT3 inhibitor, Mitostorin of that one. And we're still waiting to design studies of Ivocitinib and Enocitinib, which are the IDH inhibitors for people who've gone through an allogeneic transplant. Finally, I'll say that there was a study in people who had not gotten a transplant, who had gotten chemotherapy and achieved a remission, looking at the use of a pill called CC486. It's an oral form of a drug called azacitidine. And we've learned from a study presented in December last year that prolongs the survival by decreasing the risk of relapse with that maintenance therapy. So you're an example of where we're going, trying to find therapies that are tolerable that may prevent relapse.
Thank you.
I hope that answered your question.
Yes, thank you very much.
Thank you. Now, as a reminder, to ask a question, it is *1. But if you find your question has been answered, you may remove yourself from the queue by pressing *2. We'll take the next question. Please go ahead.
Hi, my name is Bill Alcama. I am a 64-year-old male. I've actually had AML back in the 90s and had a relapse after 2 years, and then had a bone marrow transplant in 1994. So it's been 26 years now. I'm curious about your research, Dr. Erba, and whether you have looked into a relapse. I've had a very healthy life since then, to tell you the truth. It's been very successful. I'm on no restrictions whatsoever, and pretty much just like Debbie, praise the Lord for what I have gone through and the fact that I recovered as well as I did. My first AML was diagnosed at Duke Medical Center, as I lived in North Carolina at the time. And I'm really curious about whether you have done any research on long-term transplant patients, and in the event that as I get into my 60s or later 60s, where the average age is of AML patients now, whether I have a propensity to relapse then.
So again, I have not done primary research in transplant because I'm not a transplant physician, but I will tell you this: the risk of relapse this many years, looks like it's almost 30 years after an allogeneic stem cell transplant, is incredibly, incredibly unlikely. On top of that, the bone marrow that you now have is the bone marrow from the person who donated it. And so I guess one thing, if it was an unrelated donor, then you don't really know. But if it was a sibling donor, I think praying for the long life and the absence of blood cancers in that sibling donor would do you a lot of good because you have that person's bone marrow now. But in terms of the risk of relapse, it's incredibly low at this point. And it kind of gets to the whole question of maintenance as well. Any drug that any doctor gives you for anything is going to have side effects of some sort in some percentage of people. And so the question then becomes, how much side effects are we willing to put up with for the risk of relapse? You're an example of a person where I wouldn't, even if the hottest new drug came along for AML to prevent relapse, I wouldn't recommend that for you since you've already stood the test of time. And it's similar to the discussion I just had with the first question. In the first question, she's been in remission now for 4.5 years. The value of Seraphinib is unclear because we don't know that she actually needs it to prevent relapse at all. It's one of the challenges we have. So in summary, it's hard to give you a specific answer to your question about the disease. I think it's very unlikely. However, having said that, remember that people who've been through allogeneic transplants can have a number of other consequences that I'm sure you're aware of, including endocrine problems, osteoporosis and hypothyroidism and low top of that, people have a higher chance of developing a different cancer. And so keeping up with health maintenance and seeing your PCP and talking to them about surveillance, physical exams and blood counts, I think makes sense in your case. Colonoscopies, for example. You could even think about PSAs, monitoring the skin, getting in with a dermatologist, making sure that you don't have a skin cancer developing somewhere. Those are all very important elements of the post-transplant care.
Thank you. Yes, I do all those. I watch that very diligently, and I appreciate your answer. I do want to make a plug for nbmtLINK. I was an early participant back in the 90s and early 2000s and on the peer support team. And I will tell you that I've tracked their good work all these many years, and it's been wonderful. Thank you very much.
Thank you. Thank you so much. And we really appreciate, I love it when we hear these long-term survivors. It's such a great thing for people to hear. Thank you so much.
Thank you. As a reminder, to ask a question, it is star one. It appears there are no further questions at this time, Jennifer. I'd like to turn the conference back to you.
Okay. Well, I just want to let people know I'm going to ask a couple questions myself, and we'll give everyone a chance to think if there's any other questions they have. But Dr. Erba, one question we receive sometimes from people is the aftercare after a transplant, and when does the hematologist, oncologist, what things are they in charge of with aftercare, and what kinds of things will belong with the transplant doctor, as well as their own PCP? How do you educate your patients on who's in charge of what?
Well, that's, and we started to talk about that a little bit with the last question, but clearly a very important issue given the complications that can occur long-term after stem cell transplant. For example, chronic graft versus host disease, which is quite common and thankfully typically mild or limited, still can lead to things like an increased risk of infections. And so it's so important for the PCP to be educated about potential complications in a post-transplant patient that they might not have expected. So, for example, people who've been through a stem cell transplant, they are at higher risk of infection because of low gamma globulin levels, poor spleen function, if they've had chronic graft versus host disease. And so a fever and pneumonia or bronchitis can in a post-transplant patient, even years later, can be much more serious than in the regular community patient. And so the PCP needs to be educated. And I'll tell you, sometimes that education comes directly from the patient. Our patients need to be educated because we don't know where they're going to be. They might show up in an emergency room out of town that no one knows them. They need to be educated and maybe carry information with them about being through a transplant, and if they have an infection, for example, that we need to take it seriously, not just say, drink plenty of fluids and take some Tylenol. They may need to be evaluated much more thoroughly. And the transplant doctor may not always be available for that. The other thing the other important issues are the endocrinopathies I mentioned, thyroid, gonadal, dysfunction, osteoporosis related to that, early menopause, for example, and the increased risk of other cancers. It's so important to get in with the PCP for that. And I would say the major transplant centers that do this often send back instructions to the PCP and family doc about what they recommend in terms of monitoring for cancers and endocrine problems and osteoporosis and things like that. And other centers have survivor clinics that will specialize in that type of post-transplant care. So there's not going to be one size that fits all. Each transplant center is going to decide to do this in a way that works for them and works for the community. But having the patient educated about some of the things that they are facing in the post-transplant setting is important. I'll just finish by saying, unless you're in a survivor's clinic in a transplant center, you need to remember how sick you were or could likely were when you were getting the transplant, and remember that the physicians and nurse practitioners and PAs, that's what they're dealing with on a daily basis. And your health concerns may not get the same attention in the course of a routine day in a transplant center because you're the survivor. You're the cure. You're the shining star, and you might be seen as the person who will take the least amount of time from the healthcare team. But that's the wrong approach, isn't it? I mean, you need just as much care as you did when in the immediate post-transplant period of time as you do 10 years and 20 years later to make sure that you're going to continue to lead a healthy life and not have any of the complications. And so the transplant center may not be the best place for you, and that's why I mentioned survivor clinics specifically, or just educating your PCP. It's a conversation that you need to have, frankly, with your doctor as you're moving out past that 3-month, past that 1-month milestone as to what kinds of things does your transplant doctor want to hear about as opposed to what kinds of things you should bring to your PCP. It's a great question, and I can't tell you that we have a single answer for every person.
Oh, no, but I appreciate that because that is something that is so important moving forward. And, of course, Debbie, I have a question for you, too.
Okay.
As positive as you are, and you couldn't hear me because I was muted because I didn't want to make a bunch of noise, but I was giggling when you were talking about some of the things you were giggling about as well with the lemon candies and all of that. But I'm sure that there were some really tough moments. It sounds like you've taken very good care of yourself, and I imagine it was probably quite a surprise to hear that you had AML. What are some things that got you through those toughest moments?
Well, let's see. I just felt like this too shall pass. I just, I'm very fortunate that I'm a positive person. I always have been. I'm a person of faith. And I don't know, I never felt like, oh, I'm going to die or this isn't going to work or, woe is me. I just took the approach that I am very blessed. Very blessed.
Debbie, can I add to that? As your physician, let me give you something that I've observed, and that is when Debbie comes to clinic, prior to COVID, when Debbie comes to clinic, her husband was at her side.
Absolutely.
She was in the hospital. Her husband was at her side. He was a great support. And I think about the requirement that our transplant patients have all heard about, the requirement to have a caregiver, especially in the first, 3 months after an allogeneic transplant. Part of that is clearly because of the physical needs of a post-transplant patient during that early time. But part of it is the emotional support. This is an incredibly difficult time for people. This is one of the most intensive therapies we give for any kind of medical condition. And you need somebody there to support you. And Debbie, not only was she in great health other than her AML, but she had the blessing of a husband who was at her side all the time.
That is so good. I've heard
so true.
Yeah. I've heard. I've been in oncology myself over 20 years, and I've heard the top three most of the time I hear are a positive attitude, great support, and faith. And I think you just are reiterating that to people today, and I thank you for that. But
Absolutely.
Also, I have a question for you. 10,000 steps, even after your transplant.
Well, I tried. I didn't meet it every day, but that was my goal.
Oh, my goodness. That is impressive. Is any tips for people trying to exercise as they move forward after going through transplant?
Well, I think that's very important. I know at Duke they had something called boot camp, and, if you're a competitive person or you're a person that wants to get yourself better, then you put mind over matter and you say, okay, it says here I've got to get up and, get myself dressed all by myself, which I did. You got to take care of this. You check off these things you can do. I got to, work out. I got to walk for so many minutes, or I got to do so and so. I think if you make up your mind you're going to do those things no matter how badly you feel, it helps. My friends tease me about putting on makeup every day. They say, why did you put on makeup every day? And I went, it made me feel better. It made me think I wasn't sick. You know what I mean?
Okay.
And I tried to do things like that would encourage me. Like, example, I got a wig. Well, anyway, some people wear scarves and hats, whatever, and I decided, well, Dolly Parton wears a wig, so can I. So,
I love it.
Anyway, I learned that somebody said, but doesn't it itch? Doesn't it get hot? And I thought, well, after a while, you get used to it. And I guess those movie stars that wear them get used to it, too. So, I was able to do that. That made me feel better to get up and get dressed every day. There were very few days that I didn't get up and get dressed. Of course, there were some days those doctors came in early before I had that chance, and Dr. Erba will probably tell you that's true. But I tried to get up.
I'll tell you, Debbie, you don't know when we're going to get to your room on our rounds, but I'll tell you, it was incredibly hard to get to your room before you had your makeup on every morning.
Oh, my goodness, I love it. Well, I want to offer it back to the audience. Does anyone have any questions that you thought of in between this time where we were talking? Catherine, can you remind them how to do that one more time, please?
Yes, ma'am, of course. If you'd like to ask a question, please signal by pressing star 1. Now we'll take the first question. Please go ahead.
Hello? Okay. Is there another question in the queue?
The participant is live. Please speak.
Oh, I'm sorry. I was on mute. My name is Joaquin. My son is Maxwell. We live in New York, and he was diagnosed with AML last year. He relapsed and had a sarcoma develop in his spine. And fortunately, we were able to get to it and remove it. And now we believe he's in remission again. And he's receiving Mitostorin and he also had a stem cell transplant in March. So we're trying to figure out what's the difference between the Mitostorin and the Nexivar. Was one of the questions, and the second question is, as I think her name was Debbie, mentioned how she kept his spirits up, and we're trying to work on his social development because he's 18, and it seems like he's not interested in going out. Hello?
So I will, this is Harry Erba. I'll start with the first question, Mitostorin and Seraphinib. So there are a number of drugs that target and inhibit FLT3. They come in two generations, first generation and second generation. Seraphinib and Mitostorin are considered first generation drugs. And by that, what I mean is they were both developed to target actually things other than FLT3, to be quite honest. Nexivar, as I mentioned and Debbie mentioned, was actually approved for two different cancers than it was approved. Actually, someone else mentioned that, but it's approved for other cancers. So they're not as specific and not as potent, but it's what was available. There are second generation drugs, which are much more potent and much more specific, one of which has been already approved in the United States for relapses of FLT3 mutated AML, called Gilteritinib, or Zospada is the trade name, and there are a few others in development. And so these drugs are being studied. But to get back to your question about Mitostorin versus Seraphinib, there's never been a head-to-head comparison of the two in the situation that you're talking about as a maintenance after transplant. But I can tell you that there was another study that was done in the United States where Mitostorin was compared to placebo. And in an analysis of that also showed a decrease in the risk of relapse by taking Mitostorin following a transplant. The current clinical trial that's going on in the United States is a study where people following a transplant get either Gilteritinib or placebo. And this is a challenging study, and I won't go into all the details, but some of us are concerned about putting people on a study where they might not get any FLT3 inhibitor. In other words, maybe the study should be Gilteritinib versus Mitostorin or Gilteritinib versus Seraphinib to see which one is better. So actually, it sounds like your son's doctor chose not to put him on the study and felt that Mitostorin, because of his history as a single agent, would be the best option. But if the disease were to come back, I want to tell you that there are other drugs that target FLT3 that are more potent that may become available to him. So there are still other options to consider in that situation as well. But no head-to-head comparison. Both Seraphinib and Mitostorin have been shown to decrease the risk of relapse after allogeneic transplant. The Seraphinib study was a bit larger than the Mitostorin trial, but there's no reason to believe that one would be better or worse than the other. Debbie, do you want to talk about...
Could he repeat that question again for me? His son wanted to know about...
and forgive me, you can tell me if I misunderstood, but basically his son is 18, and they're trying to help him be social, but he's, having a hard time leaving home. And if you had any recommendations on how to still socialize and stay positive, even though you're home more, and in his case, poor guy, only 18.
Right.
In a COVID environment.
I know he is in a bad situation, but personally, I wasn't able, after my transplant, to go out. I was only able to go back and forth to the BMT Center for 2 months. I had to live in Durham, away from my home. So, I will say that I was very fortunate to have people come see me. I don't know what your son enjoys doing. At 18, he might be like enjoying video games, and maybe he's got some friends that could come over. And a lot of times, they'll tell you that if you have somebody come in, of course, they have to wash their hands. Sometimes I know when we played cards, we had to use gloves and wear masks, but my friends were willing to do that. So if he's able, to have friends come visit him, even if he can't go visit them, that's a plus. One thing that helped me a lot, too, is I try to do the things that I always did before that I could do without leaving the house. You can always send people cards. You can always text with people. A lot of people, that I had not heard from, and I know I'm a lot older than he is, but I had friends. I studied at the United Nations when I was 15 years old, and I kept a friend from that study. I've never seen her since then. And when she saw, we keep in contact, like at Christmas and birthdays. And when she saw what my husband puts a post up every week on what's going on, and she saw the post, and we have been in contact every week. Some of my college friends have called me, that we were friends, but, we don't see each other very much, have been like every week I get a call from them. I get lots of cards, and I think you can reciprocate by keeping up with people that might need a card yourself. I was able to meet some people during this journey that were on the same journey I'm on, and I try to keep up with them by texting them or calling them or sending them a card. So sometimes reaching out to others when you're struggling will help you.
That's a good point. I also just want to add on there, too, that the Leukemia Lymphoma Society has some great online groups, as well as with your son only being 18, there's a lot of great adolescent and young adult groups as well. Like there's one called Stupid Cancer, which could be helpful. Not only is there some great articles and things like that on that website, but also, talking with other people that have gone through the same thing. Sometimes you can feel a little isolated because a lot of 18-year-olds are going off to school and doing different things, and you might feel like they just don't understand where you're at right now. And so sometimes talking with other people going through similar things in his particular age group could be helpful.
That's why it's good maybe to reach out to some people that... Oh, excuse me.
Oh, no, go ahead.
Now, so that's why it's good sometimes to keep in contact with some of the people that you've met that are on this journey, too.
Yeah.
And I don't know whether he's had an opportunity. I'm a little bit personal, one that goes by and says hello and people, so there's been 2 or 3 that we've kept in contact.
Well, even the peer mentor programs, too. I know we've had young people go through it that will talk to other people as well, and those relationships can be helpful, too. But if that doesn't answer at all, too, you're also welcome to reach out to me, and I'd be happy to try to give you some more resources for him as well.
I have one more question. This is hello.
Go ahead.
Hi. This is Lisa. I'm Max's mom. My husband and I are both on the line, and we're listening to the conversation. And I just had one more question, and that's probably one that you have heard quite a bit, and that is the difference between the research for AML in adults versus research in AML for pediatric AML patients. And I wonder if how do the advances in adult AML research translates into pediatric research and administration of like treatment modalities. I wonder if, there's even more of a difference, a nuanced difference between pediatric, meaning very, very young, versus pediatric, meaning an 18-year-old. And I wonder if he's more he's going closer to becoming a full, aging out of the pediatric, and I wonder if that's up to age 35 or not. I wasn't sure, but that was my question, my last question.
So you bring up the issue of research across the continuum and age continuum AML, and specifically the population adolescent and young adult, or the AYA population, which is, there's no perfect cutoff as to what's an adolescent, young adult, what's an adult, and I think the issues socially that a 35 or 30-year-old are going to be incredibly different than what a 16, 18, 19-year-old person has. Very socially different groups of people, and yet they have been kind of combined together into adolescent and young adult. Now, I'll be honest with you, one of the reasons that is done is that in clinical research, in order to make conclusions, you have to have enough people in that, enough subjects in the study to make a statistically valid conclusion. And if you limit it too much, it makes it harder and harder to do so. And so that's one of the reasons. But biologically, you can ask the question, is biologically AML in an 18-year-old different than biologically AML in a 35-year-old? And in my role as the chair of the SWOG Leukemia Committee, I've been working with a group to look at the genetic differences across the age continuum, and there are differences. There are differences between the 18-year-old and the 35-year-old. So it's imperfect, these distinctions. In terms of where's the best, how's research going, it's funny that, not funny, but the way this happened is back in the 1960s, the first advances we had in cancer were actually in pediatric ALL, acute lymphoblastic leukemia. And actually those approaches have been moved forward in terms of chemotherapy protocols for adults. But you are exactly right. In the modern era of targeted therapies, the developments, whether they be antibodies or small molecules, the developments have been mostly led by the adult population, partly because it's an unmet need. Our cure rates are much lower. Older people can't tolerate intensive chemotherapy as well, so that need has been there. And from a drug company sponsor perspective, there are just more adult patients than there are pediatric patients with leukemia. But then it begs the question, well, how do we move these advances to younger people? All I could tell you is it is happening. It's happened not as quickly as we would like it to for your son who's going through it right now, but it's happening. So, for example, just yesterday, the Food and Drug Administration approved a drug that actually I've been one of the investigators with this antibody in older AML patients called gemtuzumab ozogamicin, or Mylotarg. It approved it for pediatric patients with AML based on the studies that have been sponsored by the National Cancer Institute through a group of investigators called the Children's Oncology Group. The COG, or Children's Oncology Group, has really led the way in the development of new drugs in pediatrics. And they have some really exciting studies now that are incorporating these targeted therapies into both acute myeloid leukemia and acute lymphoblastic leukemia. So I'm going to tell you right now, my personal belief, when I'm in the hospital and I get a phone call about an 18-year-old with acute leukemia, I think it's really important to think about, which group of doctors is going to take care of them, because right now we're split between pediatrics and adult, and the pediatric docs have available to them clinical trials of novel therapies in that age group. But they also have, going along with that, all of the social supports that an adolescent might need that, quite frankly, we just don't have as much in the adult oncology programs as they do in the pediatric program. So it's important to know, who this 18-year-old is. One of my mentors said to me, he decides on which group of doctors, which team should take care of the patients depending on how the patient shows up. if the 19-year-old comes to clinic with their parents, that patient might be better suited for a pediatric approach, both socially and medically. If that 19-year-old shows up with their 3-month-old child, their own 3-month-old child, that might be someone who's more now of an adult and out on their own. And so you have to really focus the treatment on who that individual person is and not just their age. But I want to reassure you that the drugs that we are developing in adults, I'm an adult oncologist, are quickly being evaluated in pediatric populations and mostly sponsored. These studies are being sponsored by the National Cancer Institute. So a good place where our tax dollars go.
Yes, agree. One last question. Have you seen any, or what's your observation about the cognitive effects of these chemotherapy treatment, stem cell transplant, the medications, radiation? Have you seen that there has been a difference in cognitive abilities over time, or is it something that is unique to the patient?
No, you're lumping together a whole bunch of things that may affect a person's cognitive ability differently, like cranial radiation to the brain being very different than high-dose chemotherapies. But in general, I think what you're asking is there such a thing as chemo brain? And I do believe there is. Now, what's made it very difficult to sort out is that once a person has had cancer, they're not the same person anymore. Right? I mean, they've gone through a life experience that none of us want to go through, quite frankly. And they are constantly living with the knowledge that the cancer could come back, or they could have a serious toxicity of the treatments that they're getting, or it might not go away at all. And this clearly is going to affect a person's ability to think at a higher level. It just does. And so it's been really, really difficult for the clinical research to separate out the emotional impact of having cancer and having therapy from the actual biologic effect, pharmacologic effect of the chemotherapy or radiation. But having said that, I think there is something to it. We haven't found yet a way of preventing it in patients, except to say we are working very hard to get rid of things that are clearly associated with cognitive dysfunction, especially in pediatrics, such as radiation of the brain, where we've really seen the greatest impact. But it's hard to be any more specific. Yeah, and that's tough.
Okay. Well, I want to thank you, first of all, Debbie and Dr. Erba. I know we went over, and I really appreciate you making the extra time and for being here today. I feel like there was some great conversation had. If people have additional questions and we simply just don't have time now to answer, you are welcome to reach out to myself at Jennifer Gillette at nbmtLINK.org. You also can go to our website, and there's ways to contact us there. And then I want everyone to be aware that July 22nd, we'll be having our next Lunch and Learn. We'll have Dr. Annie Im, who will be presenting on chronic graft versus host disease. And if anyone needs any other information about survivorship issues, supports, feel free to reach out to us at 1-800-LINK, LINK-BMT. And so again, thank you to our speakers, our sponsors, our link partners, and for everyone joining us today. We hope that you develop something new in your toolbox in walking through this journey. Thank you and have a good day.
Thank you.
Thank you. Yeah, bye.